Pleasure for me to introduce this morning's grand rounds. Before I begin, I'd like to have a land acknowledgement. Ottawa is built on the unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. May we continue to work together and build a better future. This morning, we're dealing with a particularly, I think, potentially emotionally charged topic. It's with great honor and pleasure I'd like to welcome this morning's presenters, Dr. Stephanie Van Zanten and Ms. Lesley Sabourin. Dr. Van Zanten is a pediatric palliative care physician. She graduated from Dalhousie Medical School in Halifax, then came here to do her pediatric residency. She completed her residency, her pediatric residency here at CHEO, and then did an extra year, a fellowship year in palliative care. She is particularly interested in neonatal, perinatal palliative care, and that has been a focus and will be a focus of this morning's talk, which is perinatal palliative care, the big impact of little lives. I would also like to introduce Lesley Sabourin, is a registered nurse and is the perinatal palliative care coordinator with the CHEO palliative care team and Roger Nielsen House. Welcome, Stephanie, and welcome, Lesley, and I'll let you take that away.
Awesome. Thank you very much, Joe. I'm just going to share my screen here, and if someone could just make sure that they're able to, can you guys see that?
Yes.
Perfect. Okay. So thank you so much, everyone, for having us and coming today to Grand Rounds on this topic. It is a topic that Lesley and I feel really, really passionate about, and a really, really important topic. I think it's one that is a field that is growing immensely within even the pediatric palliative care world. Perinatal palliative care has come a long way in the last decade and a half, but relatively speaking compared to other areas of medicine or even palliative care, it remains sort of still in its infancy. I'd just like to give myself a point there for a pun. So thank you so much for your attention. We're really excited, and so we're going to get started. Our objectives today are to gain an appreciation of perinatal palliative care as a specialty and what it means and what it is, as well as the specifics to our local context, how to support infants and their families experiencing perinatal loss, and important implications for healthcare providers. And so we hope to leave lots of questions at the end as well for all of you.
So I think that this conversation does definitely warrant a trigger warning. Pregnancy loss is very common in our community, and in fact, 1 in 4 pregnancies end in loss. We have another couple statistics here that are quite impressive too, that from StatsCan from 2017 to 2001, that total infant deaths under a year are 4.8 per 1,000 live births, and then death before 28 days of life is around 3.6 per 1,000 births. And according to the World Health Organization, congenital anomalies, extreme prematurity, and traumatic birth events present a leading cause of infant mortality in Canada and the US. So we'd like to start with a definition. So Stephanie found this one. It's one of the ones that we like the best, and it's from an organization called Together with Short Lives. They're a UK organization that is really invested in perinatal palliative care. And this is their definition: palliative care for babies with a life-limiting condition is an active and total approach to care from the point of diagnosis or recognition throughout the child's life and death, embraces physical, emotional, social, and spiritual elements, and focuses on the enhancement of quality of life for the child and supports the family and includes the management of distressing symptoms, provision of short breaks in care through death and bereavement as well. So we are meeting families either antenatally or potentially postnatally with babies with life-limiting conditions. And that perinatal period is defined as essentially 20 weeks gestation to 28 days of life. Go ahead, Steph. So some of the important things that occurred in 2015, there was a bill passed, Bill 141, that required research to be undertaken to programs to develop for pregnancy loss and infant death. And it also proclaimed October 15th as Pregnancy and Infant Loss Awareness Day. Since this has emerged and since this has been in place, we've continued to have a lot of opportunity within this field, and it has really truly become a vital alternative for pregnancy, in addition to termination, depending on the family's wishes. So our target population, as I mentioned, we may be introduced with families antenatally or postnatally, depending on the time of diagnosis. We understand and know that life-limiting conditions, we expect the death to be either in utero or shortly after birth. This death occurs as a direct result of the condition, and there's no curative option that exists, or that the curative or the treatment is deemed as extremely burdensome and doesn't align with families' values. Life-prolonged interventions are not desired, and the trajectory is uncertain. There's significant amount of uncertainty around perinatal palliative care, and that requires a real detailed support throughout. Some examples of the conditions that we see, just to quickly touch on those, is our genetic disorders like trisomy 13 and 18, our complex cardiac conditions like hypoplastic left heart syndrome, anencephaly, which is often accompanied by acrania, and bilateral renal agenesis, which of course affects lung development as well. And then those babies that we meet postnatally, hypoxic ischemic encephalopathy, and prematurity, extreme prematurity. So our team accompanies families from the time of diagnosis and ensures continuity of care. And this really decreases that fragmented care provision that there's always a potential for with multiple care providers. Care is individualized and aligns with the parents' hopes and values. It focuses on the quality of life and quality of time that the families have with their baby. It recognizes and honors that unique life of baby. And there's a strong emphasis on bonding, memory making, and legacy. As we know, this supports families in a positive way in their grief, and largely due to the fact that this provides the baby with a personhood, the fact that they existed for family. Add Steph. So why is perinatal palliative care so unique? We do know that grief starts when families find out about their baby's condition. So there is a significant amount of anticipatory grief, and until the eventual loss of their child, of course. And we also know that perinatal loss can be one of the most disenfranchised grief. So there's a lot of supports required for families during this time. Families are experiencing multiple losses. A life-limiting diagnosis is devastating, and it certainly deviates away from their expectations of what was going to happen. And often families feel, that loss of future expectations and future, fantasy about their baby and about what their family would look like, the loss of their parental identity, possibly. Many of our families come back and say, am I a mom? Am I a dad? And of course, it affects social relationships as well. Prognostic uncertainty. So the severity of the anomalies can really, we know, we get to find out a lot when moms are pregnant, but we really don't know what baby's going to do until we meet baby. And this can be really challenging for families. So sometimes the lack of comfort and confidence in some providers, wouldn't expect that every provider would feel, extremely comfortable sitting down with a family and talking to them about the death of their baby. So sometimes that can really influence and make this experience unique. Compressed time is, time's not guaranteed for these families. And even when time does occur with their baby and they do get to meet their baby, it's never enough. Parents are essentially planning for saying goodbye, saying hello and goodbye all at the same time.
Thanks, Lesley. So, it's a really subspecialized area, and there's a lot of literature that has started to come out, like I said, over the past 10 years or more. And there are many people who make an assumption, or even society, that, following the diagnosis of a life-limiting condition during a pregnancy, that maybe it would just be easier to terminate because the grief would be less, or the loss would feel less significant. And I think that is, so we know now in the literature that that's not actually correct, that it's that, continuation of pregnancy is an equally reasonable and loving alternative to continuation is equally reasonable option as termination, depending on what feels right for the family. But I think there's this study that was done in the US that was published in 2018 that looks at the decision to continue a pregnancy following a life-limiting diagnosis, and this idea of regret. So this study was done using a validated quality of perinatal palliative care and parental satisfaction instrument. And so they had 405 participants, and they asked the question, do you have any regrets regarding your decision to continue your pregnancy? And of those 405, 402 answered, and unequivocally, like you can see the results here, 97.5% stated they had no regrets about continuing their pregnancy. And within this study, they were able to also provide qualitative comments. And when they looked at what were the themes that came out of how these parents felt, there was a really big piece of this decision for them allowed them to acknowledge themselves as parents and to take on parental roles, including being an advocate and decision maker for their baby, and having those parental responsibilities, like ensuring, I want my baby to be comfortable. I want my baby to have good quality time if we can. And so these were really important themes that came through and have come through in other, in lots of other literature as well. There was a really strong note by the authors about really the empathetic certainty with which families felt they had made the right decision for them. And this was illustrated by like double underline, caps locks, or sorry, like all caps, like very, very strong feelings that were able to be conveyed despite the fact that these were written answers. And when they looked at, what this allowed this decision to continue pregnancy in the face of these diagnoses allowed for really unique relationships for parents to have with their baby. It allowed them to, the consequence of deciding to continue their pregnancy resulted in the opportunity to develop this relationship that consisted of being loved, cherishing time, and meeting their baby. And that it also was a very transformative experience for parents, and that they felt positive long-term memories and actually a lack of guilt as a result of the time and the decisions that they made. So I find this study really important to highlight, and the statistic often catches people by surprise when they see it, but I think it's a really valuable piece of information for us. I think when we talk about themes that come out, not all decisions are the same for all families, and that's okay, but that these themes persist throughout the different types of populations of families who experience perinatal loss. So when there was a study that looked at bereaved parents following a stillbirth, and they also looked at the themes that impacted their experience. And this was a study, I'll just say, that was done in Ireland, where at the time termination for medical reasons was not permissible under their laws. But and half of the parents had who experienced stillbirth in the study it was expected, and for half it was not expected. But when they looked at these themes, again, this theme of maintaining hope even in the face of great loss, or potential for great loss, the importance of their baby being a person, and that their baby's life had value, and that was a really important theme, and allowed them to take on that protective care role as parents, and was really impactful in terms of their relationships, both with themselves, but also healthcare providers, as well as their partners. So I think it's a really interesting, that these themes really do come throughout the literature. Very, very common. There was a recent review done that was published this year, actually, that looked at a sort of a broad overview of the literature and collated multiple qualitative studies looking at parental experiences with perinatal palliative care following an antenatal diagnosis of a life-limiting condition with decision to continue. And really, it's the same thing of like validation at all stages of parenthood, and that their personhood is central to their experience as parents, and really that, they strive to achieve a state of quote unquote normality while pregnant, and that professionals are really enable this experience through clear communication, being empathetic, and validating the parents' experiences while promoting the dignity and being sensitive to the importance and allowing and creating a space for time. And that these really effective therapeutic relationships empower parents to be advocates for their own baby and give them a sense of control and identity. And so I think that these are really powerful themes that come through. There's a lot that we're talking a lot about antenatal diagnoses of a life-limiting condition, but as Lesley mentioned, a big portion of families that we follow receive a postnatal diagnosis of a life-limiting condition, whether that's in the setting of something like HIE or something related to the birth itself, or a diagnosis that only became evident following delivery, or for some reason was missed on antenatal screening or investigations. And so I think it's important to highlight that there are some unique challenges with receiving a postnatal diagnosis that we should just keep in mind. We know that the NICU environment can be a really traumatic and stressful place for parents. I think of myself as a PGY1 walking into the NICU being like, what is this place? I found it overwhelming. There were so many acronyms and so many incubators and tubes and wires. I distinctly remember the feeling. And so for parents who have no medical experience, it's just heightened to the nth degree. And so I think that is really important to remember as we're caring for these families. When we look at the literature, it has been shown that there can be a discomfort with introducing pediatric palliative care. And so there was a study that was done in the US, and it found that when they looked at that, only 1 out of 5 of the most medically complex infants in the NICU had received a pediatric palliative care consult, despite pediatric palliative care being available at those study centers. So we know that these most medically complex infants either have lots of technology or higher risk for significant morbidity and or mortality, and many would benefit from a perinatal palliative care consult. I think it's really important to highlight that I think actually here locally, that hasn't really been our experience. I think our neonatology colleagues do an amazing job of referring to us and involving us early. And I think that we have a really great collegial and collaborative working relationship. So I think that we're really lucky here, but just highlighting that this isn't the same experience across all centers. Important to recognize that fact. I think when you receive a postnatal diagnosis, when we think of our palliative care approach, we just haven't had the same opportunity to develop a relationship over time in the same way with these families, and that anticipatory guidance is different than when a diagnosis is received in pregnancy. That's okay, and that's fine, and we can still do good palliative care. But these factors are important when we're also thinking about the bereavement piece, where we support these families after their loss, but to recognize that these families have some unique aspects to their experience that are different than those families who did not have an experience that involved being in the NICU. And we know that the literature shows that prematurity or infant loss in the NICU may increase risk of depression or acute stress disorder and PTSD for parents. And so this is just important for us to consider and be aware of. So, what do parents want from healthcare providers? I'm going to go through these, and they seem really, really obvious. almost, but I think that it's important that sometimes to go back to these, basic, simple things, and that there's literature support a lot of literature to support each of these points, and they're really important. So I think that it is really essential that we as healthcare providers, and even just society or socially, are really non-judgmental when we're talking about different options. So as a healthcare provider, really, if we're providing this counseling, to be non-judgmental and really be aware of our own biases that may influence how we are speaking to patients and families, and that parents want to feel like they're making the best decision for their child and their family. And so equally loving parents faced with the same situation may make different decisions, but that's okay. And we need them to know that that's okay. And at the end of the day, they want their wishes to be respected and to feel like they're being well supported. And so I think that's a really big piece where, as the palliative care team, we're able to, as Lesley said, sort of follow along throughout the trajectory of care, which can include antenatal involvement through the, delivery period and afterwards. And that they want to, at the end of the day, feel an absence of regret. And to be a good parent. At the end of the day, these parents are faced with extremely challenging, difficult, overwhelming situations, and they are doing their best, and they just want to, at the end of the day, are trying to be the best parent that they can be in the face of really difficult decision making. I think this good parent concept is a really important one, and there's a lot of really good research around it. So it's one that's really important to remember. I wanted to just take a second to talk about language and how we approach families, and the impact that our language can have on experiences. Like, I'm going to preface this by saying, by no means am I like perfect. I totally make mistakes. I've put my foot in my mouth many, many times. And we're all human, and that's okay. But I think that there's both literature that talks about language and experiences of how information is delivered, but also anecdotally in bereavement, there's a lot of themes that come out, or it's not infrequent that communication at pivotal points is very vividly remembered, and that can be a really positive memory, but it can also, on the other side, we can also impact this negatively. So just to be aware of the language that we're choosing and using to when we're talking to families, and to just recognize our own biases and how this may influence our communication and discussions, and to just sort of try to remember that we should make sure that we try to keep those in check. Avoid terms that are known to be jarring. So, there are the terms, things that we hear commonly would be things like incompatible with life. This condition is incompatible with life, or not viable. When used in discussions with families, really, we've had families come back and tell us that they feel like it dehumanizes and depersonalizes their baby as a person for those parents, and can really have a negative impact. And so we should just be really careful when we're talking about language, to be aware of how it might be received. I think, it's our job to be honest. We're here to deliver our difficult information with, really hard and bad outcomes, with a prognosis that we're really worried about, or we know that we don't expect the baby to survive, maybe even to the point of delivery, and we still have to talk about that information, but the way we do it is really important. I think when I think of how we communicate with families, the term that I sort of feel is our role is to be honest, but to be compassionately honest. And so if we can do that, then we're doing, if we can be aware of that, then I hope we can do a good job. And that it's also okay to ask if you aren't sure or don't know how to address someone's baby, for example. Like, does your baby have a name? Would you like me to call them by is it okay if I refer to them by their name, or would you prefer that I refer to them by their name or refer to them as baby? Similarly, if you're talking about a family who's lost an infant or a child, you know, is it okay if I ask you about your baby, Sam? Or would you prefer that I just refer to it as your loss? It's okay to ask those questions, or you ask questions to the family and mimic the language that they are using with you, because that's giving you permission to use it. I think that a really important thing that is really key to highlight is that in society, and still, you know, in healthcare, there remains this stigma about perinatal grief and perinatal and pregnancy loss, that and sort of, as I alluded to before, that it should be shorter duration and less intense than for other types of loss, when we know that that's not actually the case at all, and that the grief in the face of pregnancy loss or perinatal loss is really immense. And this is a grief that will always be with someone. It doesn't go away. And so we should just be really aware of this. I think this is even true as a society. For a long time, you know, we don't often talk about perinatal loss or pregnancy loss commonly. And so I think, you know, we're getting better, but just that the stigma does really exist. I think when we think about the concept of grief, when I was at a conference recently, the analogy that I thought was really helpful to me was the speaker referred to grief as this backpack that you'll always carry with you. And the backpack doesn't get any lighter, but you get stronger, and other people are sort of wrap around you to help you, you know, continue to walk along with that backpack. And so it was just something that really stuck with me. When we are talking about, this is a small tangible example, but when we're taking a pregnancy or a family history, this can sometimes be difficult for bereaved parents. So for example, if someone has experienced the loss of a child, and we're just talking to them, and how many children do you have? That question, which we ask all the time, can really be difficult to answer in the face of for a bereaved parent. And so just to think, you know, are there other ways that we could ask the question to get the information that we're looking for? So for example, can you tell me about your family? And use that as your way to learn about who is their family and what do they consist of. And so these are just small examples. I think I am constantly learning, and I'm always humbled of what I am able to learn from our patients and families. But these are some things that I thought were just important to mention today. So when we talk about perinatal hospice in Roger Neilson House, you probably recognize this building. You probably walked by it thousands of times. So this is Roger Neilson House. We are on the grounds of CHEO, right next to CHEO, but we are our own independent hospice. And we are extremely lucky to be able to have this as a resource for our patients, our families, and our community. And I highly encourage you, if you've never seen it, to come for a tour at some point. It is a place that is very different than many people expect. We offer all kinds of different services here, including end-of-life care for families. We do bereavement and groups, counseling, and we have admissions for lots of other reasons. But we're really, really lucky to have this as a facility. And you can see pictures here of some of our family suites that are available when we're looking after families at end of life. And so they're they're very comfortable places. I should say they are places that are designed to be comfortable and different from the hospital and feel more like a home-like environment. We're really lucky to have this, as I said, but I also wanted to highlight the fact that you don't actually need a hospice to provide high quality perinatal palliative care. There are many, 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 many families that we look after who never come to Roger Neilson House, and that you can provide really good palliative care independent of where you are. And we really value outreach greatly and are happy to support families or patients who want to deliver in other communities or hospitals if that feels like the right fit for them. So I just wanted to make sure that came through as well. When we talk about our perinatal program at Roger Neilson House, so when we look back at where we've come from, this was in 2006. patients were referred after birth for palliative care. And in 2009, that was the first time we received an antenatal referral from genetics for a life-limiting condition. And the following year, it was our first referral from obstetrics and MFM. And this program and providing support to these families was really a labor of love for a really long time, with very few referrals a year. But as we were providing bereavement to families, it became more and more clear that there was a much greater need and a much bigger population that would benefit from palliative care, involvement of palliative care approach and expanded bereavement services. So changes started to happen, and so we expanded our services. Prior to 2019, on average, we were getting probably about 8 to 9 referrals a year. And you can see in 2019, 2020, it was about 16. And we're only growing. When we think about sort of the last year, in 2017, the ministry started to fund a perinatal hospice program. So our funding changed, and we've been able to provide even greater services. And that's when Lesley came into her role, which we are so grateful for. And in the last year, I would say we probably have on average 25 to 30 consults a year, including sort of antenatal consults and those who have a life-limiting condition in the NICU who we think will die within the sort of first, or are at high risk of not surviving past sort of a month of age. And so our referrals are really growing, and we get referrals from MFM, genetics, NICU, sometimes antenatally from NICU, sometimes from cardiology. So there's lots of ways that we receive referrals. And when we look at sort of these numbers that I'm providing, this is only just for consults where the physician team and the on-call team would be involved, and Lesley would be involved, but there's a lot more that we do. So when we look at bereavement, which is an essential component of palliative care, in the last year, for perinatal bereavement alone, there's been over 110 people who participated in our bereavement services, and that's for all comers, for all types of loss. And this graph here on the bottom right-hand corner, when we look at what it's capturing is we have a social worker whose specific area of focus is in perinatal loss, and that is within their portfolio. And when we look at the numbers, the blue columns, it's divided by years, and the blue columns are total perinatal social work encounters. And so you can see that we're growing, and that it's been, for example, in 2022-23, it was almost 1,200 encounters for perinatal loss alone, which is immense. The year before, we had a really particularly busy year. You can see greater than 1,500, but just that it speaks really to the volume of people that are reaching out and receiving our services. And when you look at the orange line, those are the unique individuals served. So in that 22-23 year, it was 137 different people related to perinatal loss. And so I think, and there are many, many families who experience loss who don't use our bereavement services, which is totally okay. And we are here to support those that need, but that this is actually really big and really, a growing population that's getting support, and we're helping. When we look there, Megan Doherty, who many of you know, my colleague, did a retrospective chart review looking at sort of 10 years of perinatal palliative care at Roger Nielsen House. And so that was from 2007 to 2017. And over that period of time, there were 85 referrals. And just interesting to look at who were these families. The average diagnosis, when we looked at this population, was made around 23 weeks, which makes sense based on the timing of anatomy scans. But the average time from diagnosis to referral was about 7 weeks. We prefer to, as much as possible, the earlier the better, we say, for referrals. It's never wrong to refer to us. So that time was 7 weeks. When we looked at those families, about just under a third had a stillbirth, and of those who were born live, by day of life 5, just over half had died, and just under 3/4 had died by 1 month of age. And so this just sort of captures these families a little bit, some of our experience historically.
So our team and our model, a little bit of history, RNH began, as we kind of mentioned a little bit already, the perinatal hospice around 2007. We all know this is a subspecialty of pediatric palliative care and an essential provision for our families in our community. And this recognized unique healthcare needs and some gaps in our services, and really has inspired change since. In 2017, it was that there was a proposal created with the Ottawa Hospital and Roger Nielsen House for additional funding, and that was what Stephanie was mentioning. This proposal was also co-designed by several parents who had a personal experience of loss, and incorporating their perspective was simply essential and really invaluable. Our team is an interdisciplinary team. We have physicians, nurses, specialized in palliative care, social workers. We have a coordinator, myself, and then rec therapists as well. And our rec therapists have a special training in talking to children and families about death and dying, and provide significant support within our families experiencing perinatal loss, because it's so unique to support those siblings. Some of our collaboration also included with our community partners, TOH specifically, in creating pathways and publishing medication guidelines and order sets for non-invasive routes for supporting babies at the time of birth or at end of life. We accompany families along the trajectory, as I mentioned, and while we do this, we are really looking at the things that are important to families. So redefining hopes is a large part of what we do when we're meeting with families. We know from the literature that families have emphasized and said that, time with baby is something that's very important to them. That absence of suffering is really, I think that's probably the main thing that families will say when we ask them, what are your worries? What are your fears around the birth of your baby? And they always worry that their baby will suffer. And it's important for us to provide this treatment of suffering that is specific to what the family perceives as suffering as well. Creating memories is really important. Maintaining that role of a parent, like Stephanie had mentioned, and, really emphasizes that personhood of baby when we encourage this and support this. A lot of this can be supported by, nurses and physicians and healthcare providers at the bedside, and really modeling that care for baby and supporting families in meeting their baby. The entire family is involved in this. We support siblings and grandparents, and we also encourage as many people to meet baby as possible, and that holding baby is very important. We do meet families and support families in bereavement who have had very, very short times with their baby, or something sudden has happened, or they've chosen to end their pregnancy and didn't get a lot of normalization around these acts before, and didn't hold their baby, and they express significant regret about that. We do a lot of photographs, memory making photographs, and ink prints, castings, anything tangible. Essentially we're creating a life of this baby in a very, very short time. The birth plans that we develop with families, we have two different kinds of birth plans. And one, we meet families that continue their pregnancy, which has a really large focus to advanced care directives within it, and then a long list of wishes and planning for around when they meet their baby. And we also have a memory plan for families who are choosing to end their pregnancy. So we will support families, at the time of their diagnosis, supporting them in their decision making, and supporting them through that experience as much as we possibly can. And often that is simply, supporting that and normalizing that act of taking those opportunities to love baby and be with baby and to be their parent. And that could be during pregnancy. So until their procedure, there's this opportunity to bond. There's this misconception that, without attachment or bonding, we won't have any pain or grief. But we know from the literature and we know from families that's just simply not the case. And encouraging bonding actually supports families in a very positive way. And then, of course, there's bereavement. So desired location of care, our services are available 24/7, and that is essential within our world. And we can provide this care in multiple places. And this is very dependent on the family's wishes, and it's also evolving. Families can plan for one thing, and this can change, and we can support things pretty much on the fly. Some may end up staying in hospital, and that is where they're feeling comfortable. And we do see this often in the NICU because families have grown to truly trust their providers within the NICU, and that is the place they want to be. And then we can also support families being at home or being at home for a short time and maybe coming back in to hospice or hospital. And then, of course, hospice. We have had situations, we have a picture here of the butterfly garden, which is our beautiful garden between TOH and CHEO. And we've actually had experiences with families where we've taken babies here while on the ventilator and done a compassionate extubation there, and then came back to Roger Nielsen House for end of life. So there's lots of things to explore with families around what this looks like for each baby. So there's a lot of planning that is involved in this. So perinatal bereavement, our program is, as you saw from the statistics that Stephanie shared, is very robust and has been providing this care for quite some time. I have the privilege to be a part of this and co-facilitate within the perinatal loss program and within our pregnancy after loss program. And it's truly an experience I can't explain, learning from parents in this way. And truly, I could have spent a million years in a classroom and never learned what I've learned from families in bereavement group. That's for sure. So we have the patients that we support and the populations we support as families who've had an unexpected stillbirth after 20 weeks gestation, our antenatal diagnoses that are choosing to end their pregnancy. We will support them in bereavement as well, and have had a couple of opportunities, which doesn't always happen depending on numbers and mix and how things look within the groups. But we've had a couple of opportunities to support those families in a different environment, just outside of the other populations. And it has been, it looks very beneficial, and families have shared very differently in that, because often these families carry significant amount of guilt, and even describing their experience to others who've had different losses can be extremely difficult for them. Even though group is a very safe place, this can be a real challenge. We have our antenatal diagnoses that continue their pregnancy, of course, post-delivery diagnoses, and then our losses in the NICU. And neonatal death, we have a guideline around it being between birth and 28 days, as mentioned. And then the other ones, as mentioned, is over 20 weeks. We would love to support all pregnancy losses, but our resources are limited for that enormous number. So this is a list essentially of our bereavement supports. Bereavement is definitely a palliative care treatment, essentially, or a provision of support. And these are the groups that we offer that are specific to perinatal. So we have perinatal loss group, which is a closed group. It's usually 8 to 10 weeks, depending on the participants' needs. And each week we go through a theme, misconceptions of grief. There's one session where they write a letter to their baby and really express the emotions that are really difficult to talk about. And very often these families become quite close and see each other outside of group and really create a community of their own. Individual counseling, of course, is provided by our bereavement social worker. Grandparent group, as grandparents are often very forgotten. It is a drop-in group. Sibling support, pregnancy after loss, which is also a drop-in monthly. And then we have peer matching programs and these are families that have been through these experiences in the past and really want to give back and support other families moving forward. So something that's so unique about this population is their intense desire to give back and form community in their grief, which is, it's essential. This is one of the ways that families can provide legacy and also a platform or a place that they can gather and actually talk about their babies, because this is what families want to do. They want to talk about their babies. They want to say their baby's name. The Ottawa Butterfly Run is a huge way for families to achieve this important and essential aspect of their grief.
So, we've talked a lot about our program and where we've come and how we've expanded it, and we are working really hard to continue to expand our services and our portfolio. We are starting to develop a program of research. We really want to learn from, we've are just working on analysis of a study that's evaluating the experiences of our families here locally, both with quantitative and qualitative information related to their perinatal hospice and support services received, so that we are better informed on how we can serve them even better. We are looking towards, really, as Lesley was mentioning, these families who are creating memory plans or being supported prior to a termination of pregnancy. This is a population that is really under-recognized and understudied in the literature, and I think there's a lot here where we could improve. So we're looking at how we can support those families through and using research to inform those decisions. And so we're really excited about, what the future looks like for perinatal palliative care. And we're really grateful for all of those people who collaborate with us and who, we have amazing nurses, doctors, social workers, rec therapists who are not just at Roger Nielsen House, but, in the community on labor and delivery, our NICU colleagues and the nurses in the NICU. It's been really amazing to collaborate with such a broad team because this is something that we all do together and we work towards together. So we're really grateful and excited about what the future brings. We wanted to take this last slide just to share a poem that was written by one of our bereaved mothers about the loss of her son, Avery. So I'm just going to read this to you, and then we'll have an opportunity to have questions. We all grieved together, then they grieved for me. Now my grief is endless, with no one there to see. Our cells dance together, an amazing work of art. Losing a baby is losing your body, soul, and heart. I held you, but never heard you cry. I birthed you just to say goodbye. So much love to give you, but it's trapped inside my heart, hanging on the edge of completely falling apart. Because of the cry that never came, the sun doesn't shine as bright, but you will forever be my baby, and I'll never forget that night. That night I held you and studied your sweet face, the night before months of just staring into space. My sweet little angel lay across my chest. All I wanted was to bring you home, but you were born to rest. Watching, waiting, begging for the breath that never came. Instead, you lay still, and nothing will ever be the same. My entire body aches to hold you. You're worth every fallen tear. Not remembering your face is now my biggest fear. Now your eyes live in the stars, and your tears fall with the rain. Sweet dreams, my love, until we meet again. We wanted to thank you for your attention, and we are happy to take questions.
Thank you so much, Stephanie, and thank you so much, Lesley. I don't know how you could read that without bursting into tears, and the kind of work you do has an emotional capacity that can't be described in words. And I thank you for your important and hard work. Lesley, you did a wonderful job describing the program and aspects of it that I myself had never even considered. Stephanie, you know, I've got the gray hair to show it. It's really something when you think back on somebody who came in, and you remember when they came in as a resident, and you see them transform from somebody fresh out of medical school to somebody who is subspecialty expertise, emotional capacity for caring beyond description. And I'm sure there's others among the participants this morning that can't believe the transformation. What you've maintained is a passion and an enthusiasm for care that was evident the first day I met you. So thank you, both of you. And I'd like to open this up for questions. As someone has experienced this kind of loss that you're talking about, very close to family, or part of my family is, can't describe in words how important the work is that you do. Questions for Lesley and Stephanie? Do I have to? Oh, Erica, Dr. Brisiak.
Thanks, Joe. And thanks, Stephanie and Lesley, for a wonderful overview of the great work you guys do. We are indebted to your team. We enjoy our interactions, value your expertise, and are grateful for what you do for our families and our staff. So, you know, recognizing that this is very hard for, you know, the medical caregivers of these families and these babies, and your team provides invaluable support to all of us, everybody that's involved in that baby's journey. So thank you. I also appreciated the recognition of, you know, some of the less understood or appreciated effects and impacts on these families. You know, we certainly learn these things, and it's really quite impactful to hear how affected the families are and how long that effect is. And so just reminding people, you know, of that, and to be mindful, and that goes out, as you see, for years. You know, we are very fortunate to have your service here. I was glad to hear you remind us that you provide your service remotely or to other locations, not just within the hospital, within the home in Ottawa, or within Roger Nielsen House. And I know we've done that with babies who have moved from the Ottawa area out to their home environment. And it's so important to be in the home environment because, you know, when they come here, we sort of put them in a vacuum, remove them from their onion layers of support, which further compounds the difficulty in dealing with this. Do you also provide support for families and patients who you have not met here or will never? So for instance, you know, we get advice calls from around the region, and sometimes it's not appropriate or necessary to bring that family or that baby here. And, you know, is it possible for you to then support those medical teams and those families without them ever coming here?
Absolutely. We like our mandate and we are here to support anyone who needs our services within our catchment, and you know, across the province we collaborate quite heavily actually. As Pediatric Palliative Care, we're sort of working on models of delivery of care, and perinatal is a big subset of that, but that as subspecialized pediatric palliative care providers, we are here to support anyone in the province who needs us. And there are different catchments, different people in different catchments. But if it was someone who called us and there was either a desire, you know, an antenatal diagnosis and delivery at a local hospital, for example, we, like Lesley, would absolutely work with those families, create a birth plan, you know, that outlines exactly what their wishes are, and provide that to the delivering labor and delivery unit. But in addition, we recognize that comfort with loss is less in centers where they don't do that as much. So we would be open to providing education or support. Like Lesley's amazing at sort of checking in with the nurses and what do you need, and here are tangible examples of how we might support or word things when we're approaching these families. And from a sort of medical perspective, if I got a call from someone in a like remote NIC or NICU not within Ottawa asking about sort of, I feel like this baby is experiencing really distressing symptoms, or where do I refer them for bereavement, or, you know, I would be more than happy to help support those families. Absolutely, any of us would. Lesley, I don't know if you have anything to add there.
Yeah, just specifically around, you know, supporting families who have a life-limiting diagnosis in pregnancy. Like Stephanie said, we would build the birth plan, but a lot of effort would be going into supporting them within their community. And that could mean like even with their family physician, again, with their nursing team and their physicians that are caring for them at time of delivery, and also like providing extensive education for the staff depending on what's needed. So that's all part of the evaluation and the, you know, ability to provide good palliative care and support it from our team.
That's super.
Thank you.
Thanks so much.
Dr. Redpath, another Stephanie.
Another Stephanie, and I waited a moment because I was actually crying, so couldn't ask a question. Sorry. Thanks, guys. And as I say, you know, I honor your services, and I'm so appreciative of everything you do on both campuses that we work. I just think two sort of questions I wonder about, since you're building this program and there's so much work to do. So just touching on one thing that Erica brought forward, you know, we do, and again with the transport hat on, we do provide services across the region. So I just wonder whether or not we could touch base offline about developing more of a structure for, I know our transport team have a very, very hard time leaving babies in the community. They're always asking us to follow up on social work, and you know, just like anyone, we can't take it on, but whether or not, you know, how that we plug those gaps and try to do our best. We might not succeed, but I think that that's an area that Erica brought forth that's really important. We see it weekly. And then the other part I wondered about, given the Stephanie, you mentioned a research lens, there's so much work to be done, is also the subject matter that we've talked about in terms of, you know, just the volume of losses in the NICU and the impact on care providers, and where, you know, as the MRP of these patients who are caring for the intensive care aspects, you know, then where and how we pivot to providing, you know, support around the loss and support for our teams. And, you know, I guess my question is research into who's the best provision for this. I always worry that the language that we use and shifting from that ICU to then changing perhaps direction of care. Do we do it right? Do we do it well? Where and how can we improve? Sort of thing. You know, are we the right care providers, or is it working in tandem with you guys, or is a switchover? So I'd just be interested to have some feedback from parents in that domain. I think to improve how we provide services in the NICU.
And any of those, like, if thoughts, any of you really who have thoughts that come in about some of these questions that you feel are unanswered or important, like, please send me an email. Because we are, like I said, we're really like working to capture this information from this population in a different way than we ever have before. So we're happy, like, fire me off an email, happy to chat about it and incorporate that in.
Thanks, Dr. Van Zanten. I wanted to point out to the group that Dr. Van Zanten, Stephanie, is an assistant professor at the University of Ottawa, and I know that with her colleagues, getting involved in scholarly activity around this very important topic will help not only people in this region, but people in other regions as well, as we spread information and disseminate information, transfer knowledge regarding how to approach such an emotionally charged and difficult topic. Dr. Brisiak, your hand is up again.
I know, and I'm cognizant of the time. I didn't see any other hand go up. And I just remembered something that came up recently, a conversation I had with one of my colleagues about spiritual care. You know, we used to have.
Thank you. Thank you.
Yeah, Gerardo and Rasheen. And I know our families, you know, everybody brings a different angle, a different lens, a different level of comfort to these families. And we've been without that spiritual care lens for a while. I know politically, it's become something that is kind of trending away, you know, in any of the public facing organizations. Any discussion or thoughts or feedback from families about, you know, us needing that? I certainly in the NICU have felt that piece not there, and wonder whether or not that's something that we should look at bringing back if we can.
Very good question. And, you know, is there a role for us to have better links with imams in the community, rabbis, preachers, priests, ministers, so that every buddy can have the support if they feel they need it? But I'll let Stephanie address that.
Yeah, so I think spiritual care, and you know, when we meet with families, like we talk about all aspects of their life, like not just advanced care planning, but like who are your supports? Are there spiritual or religious facets to your life that are important that we know about, that we can support you? I think within CHEO, we're extremely lucky actually to have Jeff Fitt from spiritual care, who we work with a lot. We try to make sure that it's something that we offer to every family. I think not all families take us up on this, but having had conversations with him, I just feel like he has this presence and ability to listen and communicate in ways that is so impactful. So and he is very he's really lovely and amazing at what he does. So I think we are lucky to have him, and you know, he's a really good resource. In terms of the spiritual care aspect coming up in bereavement, do you hear, Lesley, much of, I don't participate in bereavement as physicians. We are not part of that process as intentionally, but Lesley, I don't know if you have had any sort of feedback from families.
Yeah, I think for the most part, I feel like families are being supported through that because they're usually, when it's that important, it is something that they are bringing up, that they are talking about, that I think that that's occurring. Whether it's occurring within the hospital or not, I can't say 100%. I would strongly advise what Stephanie did to involve Jeff. Jeff is an absolute dream. He is amazing at speaking with families and supporting families. Unfortunately, there's only one of him, but he is remarkable. And he has actually even helped co-facilitate some of our bereavement groups when we instill sessions on spiritual care. And we don't always, because there's some people who just don't, and some groups that don't require that, or like the participants are just not needing that. But he will come and speak, and he has an amazing way about him. And I think, like Stephanie said, we talk a lot about spiritual care with families, and I do a lot of prepping around and even meeting imams and spiritual providers for families, just as they're, you know, explaining and discussing their situation and supporting that in the way that we can from a medical perspective. That answers your question.
Thank you very much, Lesley. Our time together has drawn to a close this morning, but I know that there's still people who may have questions or issues or ideas they'd like to bring up with Lesley and Stephanie, and I know that they would welcome your emails or other ways to contact them. Both of you, thank you for an amazingly well-coordinated tag team presentation on this, and I applaud you. I admire and respect the work you do beyond what I can say with words. So thank you again this morning, and thank everybody for their participation. We had a great turnout.
Thanks so much, everybody.
Thank you very much.